Hi everyone, and welcome back to the GuideWell Insights Lounge. This is Kate Warnock live on location at the 2017 AHIP Institute and Expo, and we have one of our favorite guests ever, Mr. Mark Stryker. Mark, welcome back.
Hello, Ms. Kate. How are you?
Doing great. So, Mark,
Excellent.
Of course, you're the Vice President of Business Development. Is that the right way? Of GuideWell Connect.
That's
so,
right.
Mark, let's start, with just getting your thoughts on, you've been here at AHIP. It just kind of really officially kicked off. What are you hearing on the floor?
It has been very interesting. From Joe Swedish to a lot of the other speakers, the themes have been really consistent, and it's been cost, medical cost, admin costs, cost of care continuum cost, you name it. And so that has been a consistent theme all day long. It's been interesting because unless those folks were talking offline and coordinating their messages,
right,
everybody's pretty much thinking the same thing.
Wow.
It was very interesting to hear that Joe Swedish said for Anthem that they're expecting by 2018, I think, that pharmaceuticals cost may be more than 50% of their total medical spend.
Wow.
So that trajectory, and that's up from 30% just a little while back. So and another one that was interesting is that the pharma cost was now higher than their total inpatient medical costs that they pay every year. So
phenomenal. It's
just interesting to see that being so much on the minds of the leaders out there that are talking, and so
yeah. So no doubt, on the minds of consumers too, and I know that's where GuideWell Connect kind of comes in, right? You're
that's
a consumer-facing organization, and you help health plans really help their members get the most out of their health plan. Tell me what's new on the horizon with GuideWell Connect.
So this is a big year for us in terms of extending now from what we've historically done in consumer-focused sales and marketing for acquisition and renewal and retention, and now really pushing the closure of that loop with member engagement. So taking those same tools and competencies that help us understand how to talk to consumers, how to help them make great decisions about their health plan purchase, and now turning that engine towards how to help the members of the health plan make great decisions about their health care in ways that have the double benefit of supporting their personal health status and supporting the P&L performance of the health plan. So
it's a win-win.
It's a win-win.
Yeah.
And so for us, that it's important because that puts us at every key touch point in the consumer cycle that the health plan is concerned with.
Right.
And it helps us build business focus with the health plan around not engagement for its own sake, not consumer experience for its own sake, but really nailing it down to specific interactions that support specific benefits for people and for plans.
Well, something that we've heard from some of our other speakers is really around relationship building. And it sounds to me like what GuideWell Connect is striving to do is really helping the health plan make that relationship so that as renewal comes up, every year it's a choice, with consumers, they want to come back.
They do.
Yeah.
That's the thing. That's the beginning of the virtuous cycle that you want to build.
Right.
Right. And that's what is showing for us that's there to be built.
Yeah.
As we see that. And one of the big litmus tests for us in terms of now engagement and member engagement was, in addition to business outcomes and hopefully health outcomes for people that are really absolutely important, well, the other one was, how do the people feel about it? How do they really come out of that interaction with their health plan, feeling about that health plan? And one of the best stats that we had out of this was, dropping when health plans engage with their members, sometimes the members don't want to engage with them. It happens.
Right.
And so just seeing that negative outcome drop by 99.5% in the first year that we were doing this.
Oh my goodness.
Relative to other solutions out there.
Wow.
That told us exactly right. Taking the way that we understand how consumers behave, how you interact with them, and then pointing that at a member to help them make continuing good decisions. It works. It works, and it works because the members tell us it works.
Wow. Well, you have so much to talk about, and I know we're going to have you on camera again, but
yes.
Tease for us. We had, right before we joined back with our audience, we just had a really fascinating conversation with someone that's going to be presenting tomorrow, Dr. Eric Rifkin. He's with Johns Hopkins School of Public Health. Tell us a little bit about that conversation.
Well, that was great, wasn't it? What an amazing guy. Been in the business for a long time.
He's a researcher.
And just brass tacks. He's in it for the understanding, the learning, and driving the evolution of care out there in ways that benefit people. And so the way that he talked about helping consumers, people, understand the statistics, where do they fit in terms of these different conditions out there? And what are the probabilities that really this thing is or is not going to impact me?
Yeah.
And then how does that help a person make a decision about their own care? And his, what I got from him is his commitment to that is astounding.
Yes.
And so I think for all you folks watching out there, that's one not to miss. It's going to be a neat time with him, and to see what comes after that. Now, once you folks out there and all of us get keyed to the work that they're doing, I can't wait to see what happens next week.
Yeah, absolutely. So that's Dr. Eric Rifkin. It's going to be on set tomorrow with Andy Lazarus and talking about this really amazing decision-making tool. I think their interview is around 11:30, but don't worry, we'll tweet it out. So if you're following AHIP Institute, hashtag AHIP Institute on Twitter, you'll see it. You can also go to our LinkedIn company page, GuideWell, and Mr. Stryker as the Mark Stryker. I know that you're going to be tweeting some more too.
Yes, MK, I will be there.
Right.
At MK. Is it bad that we talk to each other in our social media handles? I don't know.
I think people get it. So we're social people. All right, Mr. The Mark Stryker, thanks for joining us here on set at the GuideWell Insights Lounge. We're going to be up with just another minute with another fascinating interview. Keep watching. everyone, and we're back live here at the GuideWell Insights Lounge. My name is Kate Warnock, and we're here at the AHIP Institute and Expo. I'm delighted to bring our next guest, Dr. Gretchen Alkema. Gretchen, welcome to the interview.
Thank you so much, Kate. It's a pleasure to be here.
We are delighted to have you. So, Dr. Alkema, you are the Vice President of Policy and Communications for the SCAN Foundation. You have a really important topic. You're going to be speaking later tonight or later today. Just a little while from now.
This is the preview.
So let's talk about what you're going to be addressing from the stage. Maybe give us a little overview of your talk.
Sure, happy to. Well, the SCAN Foundation is an independent public charity in Long Beach, California with a national focus. And we focus on how can we improve healthcare delivery systems for older adults who have lots of chronic health conditions and challenges with their daily living, but want to stay at home. Nursing homes work for the rehab, for tune-ups, for post-surgical intervention. Right. That's not really where older people want to live, especially when they have lots of needs and lots of difficulty living independently. Folks want to be in their homes and communities, help their family caregivers be supported in the process of meeting their needs, and be continuous part of their lives as they've been all along. So we focus on how do you change healthcare delivery systems, both delivery and payment, in order to help make that happen.
So let's talk about maybe the size of this audience that you're addressing. Your consumers, the aging baby boomers in particular. I've heard it be called the silver tsunami. Do you have some figures that you can give us that kind of give us an idea of the size of this population that you're trying to provide better care for?
Sure. So when we think about the aging of the generation that we call the baby boomers, ultimately 10,000 people a day are turning age 65 and are living much longer than their parents. So we think about that generation as a group, but ultimately what we're really talking about in terms of our work is focusing on those individuals who have chronic health conditions, oftentimes multiple chronic health conditions, as well as challenges in daily living. And by far, those are within a population of older people. If we wanted to take a kind of a cut point in time where it's most present, you look at a group about folks who are over age 85, and we're having people living much longer into the future. So that's kind of a sensitivity point when we think about generations. But ultimately, people who are younger than 65 can have these situations as well. People with physical disabilities, mental health needs, people who are aging in with a disability, and need to really have a kind of refashioned healthcare system to help meet their needs as well.
Absolutely, and I'm sure the other population that you're benefiting are the caretakers.
Absolutely.
For these older, the older parents, loved ones that are getting these, multiple chronic conditions, it does become more of a challenge. So I'm sure that your work and your focus is going to be benefiting them as much as it is the individual with the conditions.
We're really delighted to work with lots of partners who are leading in this space and thinking about folks who are those family care supports, people who are doing things like, helping mom take care of laundry and grocery shopping, all the way up to doing physical hands-on care and having a loved one maybe live in their home with them, as well as people who do that really intense work of being long-distance caregivers.
Right.
Mom lives and dad live in another city, or an older sister, older aunt was living in another city, and being that ongoing monitoring and management of a person in an assisted living facility, in a nursing home, because that's where their needs are taken them, an Alzheimer's Day Center, or a living situation where family is still very deeply involved, even if a person isn't living with them at that time. So supporting family caregivers is paramount to making sure that systems really function well, because effectively they are the default care coordinators inside of a care delivery system.
Absolutely.
Why I think this is so pressing is that as we watch the boomers age, the reality is that they had less children than their parents did. So we've had a lot of conversation about the sandwich generation, people who are in their 40s and 50s, sometimes 60s, who still have young children living at home and are managing supports and care for aging parents. That was true for boomers themselves to be in that sandwich, but I would say it's even more pressing of a need as millennials age, because boomers had less children, as well as they had children in later stages in life. So you have someone who is a millennial, say in their mid-30s, young children, and maybe mom and dad are in their 60s because they had children at a later age. So we're watching those generational spans lengthen out as opposed to being more compressed together like we did in the past.
So that's definitely some of the trends then that you're watching from the SCAN Foundation and trying again to think of the right solutions that are going to help anticipate and correct where there are gaps.
Absolutely, really looking at that.
All right, well let's go to your next question then.
Sure.
So how is it that the health industry can serve seniors who are managing these multiple chronic conditions, but still keep care affordable? We just had Mark Stryker was on right before you, and he was saying that, listening to the speakers from the AHIP stage, he said it's almost as if they send each other a memo. Everything comes down to price and cost.
Sure.
So especially for this population, what are some solutions that you think we can better manage?
It is a great question. And when I think about, ultimately the service point of delivery is at the consumer. It's at that older adult, along with the support of their family caregivers who are engaging in the care delivery. And that is where, that's where costs are born, is in that experience of utilization. But oftentimes when we think about delivery system transformation, strangely enough, we can actually forget the older adult and the family caregiver and think about the big payers. We think about Medicare, we think about Medicaid, we think about the employer-sponsored plans, and those folks as being really part of the payer driver mix. I would say let's focus back down at that consumer level. Let's ask people one fundamental question is, what matters to you most on this visit? What matters to you most right now? I'm going to put my nickel down that people don't say, I want my hemoglobin A1C to get down to this level, I want my blood pressure to be X, Y, and Z. People are saying, I want to be able to go to my grandchild's graduation. I want to be able to go get my own mail if I live in a rural area and I've got to walk a quarter mile down that road.
Right.
I want to be able to, manage the things in my life myself. I want to be able to take the stress off my daughter on being able to get transportation to get the kinds of things that I need. All the kinds of things that people focus on when you ask them what matters to them is about daily living, or what we'd call function. It's about how people are functioning every day.
Right.
And it's chronic conditions and their attendant effects on people that decrease their ability to function independently. And that's when problems arise. That's when people get scared, because their vision about what life should be like and what the reality is and their functioning at that moment are colliding.
Right.
And so how do we get back to that perspective of what are people's needs, values, and preferences that are driving their experience through healthcare delivery, and help recalibrate that in a way that matters back to me as the consumer and my family caregivers who are helping support me in that experience.
So Dr. Alcala, I have to, it's just remarkable to me. We had a guest here in the Insights Lounge, Dr. Angela Volandes, was here earlier, and talking about the conversation. And really what he was saying is that, just like you mentioned, if people ask what matters to you most, what are your values, and allow that to really drive, okay, then this is the right kind of care for you.
That's right.
We have a real sea change, don't we?
I think it's a huge sea change, and we would say at the SCAN Foundation that oftentimes the conversation has been focused on what I would say end-of-life care, palliative care, really, really important, right?
Yeah.
I would say there's many conversations. We can start way upstream about saying, what matters to you? Once a person starts to have a chronic condition, that means it's not going away. It's going to change the trajectory of their experience of care and their care interactions. So let's start to talk about what's most important to you. Is it about pain management? Is it about, continuing to do X, Y, and Z activities? Is it about continuing to be able to babysit the grandchildren or be able to go to church on Sunday? Whatever that is, focusing care around that, and then thinking about the variety of conversations that actually support that. We at the SCAN Foundation have put together a 10 things guide, 10 conversations you should have with your family, 10 conversations you should have with your doctor. What are the top 10 issues that are present for you as you're growing older with having more needs? And in that embedded is what I would say the conversation about what's important to you when you're at the end of life. There's lots more that comes before that.
So why don't you tell our audience, where can they access that wonderful resource?
Sure. So our website is www.thescanfoundation.org, and when you go onto our homepage, you'll see a big link at the top called Aging Well. If you click on that, you'll be able to get to the whole list of resources, as well as some interesting informational videos.
Well, Dr. Gretchen Alcala, it was wonderful having you here in the GuideWell Insights Lounge, and I know you're going to give a wonderful presentation in just a little while, so thank you for giving us a taste of what others will get to hear here.
Thank you so much,
My
and best
pleasure.
of luck to you at this conference.
Oh, thanks so much. So this is Kate Warnock off, but we'll be back up in just a moment.
Even when we're talking?
No, when we're talking, you look at me.
Okay.
Hi everyone, and we're back live here at the GuideWell Insights Lounge. This is Kate Warnock on location at the AHIP Institute and Expo. I have Mr. Michael Chernow. Michael, welcome to the interview.
Thanks for having me.
You're welcome. So I'm going to say your title. You are the Leonard D. Schaefer Professor of Healthcare Policy and also the Director of Healthcare Markets and Regulation Lab at Harvard Medical School. So you flew in all the way from Massachusetts to be here with us, and I know you're getting ready to go on stage. So we're going to be really sensitive to your time. Let's get right to it. Dr. Chernow, tell us more about value-based insurance design and how might this help seniors and those with chronic conditions who might otherwise forego care?
Right. You know, Kate, we live in an era where patients are being asked to pay more out of pocket when they go to the doctor or the hospital, when they go to the pharmacy to buy their medications. And that's largely done because payers are trying to control healthcare spending, but it creates a financial barrier for patients to access the care that they really need, particularly those who are trying to manage chronic conditions. So if you have diabetes, you're paying more for your medications, you're paying more for your glucose strips and a whole series of things like that. The idea behind value-based insurance design is to reduce the financial barriers for those high-value services, the high-valued pharmaceuticals, the high-value medical care services for individuals, to allow them to access the services that we want those people to access without having to pay a lot out of pocket.
Okay, what's the secret sauce? How are you managing to do this? How are you making this care more affordable?
Well, usually what happens is the insurance companies change the benefit structure to allow certain services to be covered more generously than they otherwise would have been. So there's examples of large companies, for example, that make patients or their employees pay less for their blood pressure medication, for their glucose medication, things like that. It really is a tweak to the benefit design.
Okay.
It doesn't necessarily save money. It might save money depending on how you design it. There's a possibility of charging people more, for example, for low-value services, which is also part of value-based insurance design. It really is dependent on the organization that is implementing these types of policies and the extent to which they want to be more nuanced in how they set up their benefit packages.
Okay.
But it's very rare. I talk to a lot of insurers. I'm here. There's a lot of insurers here. I talk to a lot of employers. I actually chair the benefits committee at Harvard University, which advises the provost. And you rarely find any payer, an insurer or an employer, that really wants to charge people with chronic conditions more for those services that are really important for those people to use.
Sure, sure. All right, next question then for you. So how might payment reform make primary care a more viable career for today's med students, and can it help solve for the shortage of primary care physicians?
Yeah, so completely different ballpark of question, but nevertheless I will take a stab at this. Historically, we've paid physicians in this country fee for service, and the general thinking has been that the fees for primary care physicians have been relatively low. There's also a belief that there's a considerable amount of waste in the system. Some estimates suggest as much as 30% waste in the system. The new payment reform initiatives all are designed to allow the delivery system, broadly understood, capture some of the savings if those efficiencies are taken out of the system. The key question is who gets to keep the share of savings. So if we reduce an unnecessary hospitalization, if we reduce an unnecessary stay in a SNF or some other unnecessary post-acute care, if we reduce the number of unnecessary imaging that's done, all those savings under these new payment models get shared with the providers. The question is whom? Most of the models now that are population-based favor the primary care physicians in terms of keeping those savings. The savings accrue, the portion of the savings that are shared accrue to the organization that employs the primary care physician. It could just be a primary care physician group. It could be a larger organization that employs primary care physicians. That process, should it play out in the future, conceptually would make it more rewarding to be a primary care physician, because the primary care physicians are central to these population-based payment models. And if that proves to be true, and we're a long way from proving it to be true, but if that proves to be true, it will make primary care, I believe, a more valued part of the healthcare delivery system.
Well, I wish we had more time to talk to you. We have just one more question for you, though. So, what is your opinion on quality measures in use to gauge clinical performance? Can they be improved, and what might those look like?
Sure. So, again, you've saved the hardest question for last. One of the challenges for all of the transformation of the healthcare system is how do we measure quality? And there's an enormous amount of effort going on to quality measurement. There's National Quality Forum, there's NCQA, there's a number of organizations. CMS has huge initiatives. AHIP has been involved in a number of initiatives for quality measurement. The challenge has always been that although we've made a lot of progress, there's huge gaps in quality. A good example would be we don't have great measures around the quality of diagnostic care. How well are people who come in with unknown ailments being diagnosed?
Right.
Just one example. I think the improvements going forward will involve two things. One is coming up with better measures, which we're doing a lot of, but more importantly, I think it's important to understand that the way we think about quality measurement should not be simply about the measures, it should be about the measurement system. What is the system of measurement? How do we build a series of questions and a series of actions to understand who's providing good and who's providing poor quality? And so that requires understanding how the measures relate to each other. It involves measuring for a purpose, understanding what you're going to do with the measures. How you measure quality is different if your purpose is to inform consumers versus if your purpose is to pay providers, because consumers need more targeted measures about specific providers, whereas for payment you might just need to know aggregate quality for a given delivery system. So more focus on why we're measuring quality and more focus on the system around the quality measures, not just the measures themselves, is I think where we're going to have to go in the future.
Well, I know that you're going to have a wonderful audience waiting to hear you as you get ready to jump on stage here at the AHIP Institute. Thank you for spending your time with us here in the GuideWell Insights Lounge, Dr. Truno. So my name is Kate Warnock. Please keep watching. We'll be up soon with another interview.
Great, and thank you.
All right, thank you. everyone, and welcome back to the GuideWell Insights Lounge. This is Kate Warnock coming to you live on location at the AHIP Institute and Expo. We have a very distinguished guest joining us in the lounge, Dr. Patrick Conway. Patrick, welcome to the interview.
Thanks for having me.
Oh, we're happy to have you. So Patrick, of course, is the Deputy Administrator for Innovation and Quality at CMS, and you're also the Chief Medical Officer. All right, so you are going to be addressing the AHIP attendees on the nation's progress with alternative payment models. How are we doing as far as that adoption? Are we destined to always be a fee-for-service nation?
We've made a lot of progress. So if you go back to 2012, we had 0% in alternative payment models. We now have over 30% in Medicare in alternative payment models, and we have 85% plus tied to quality and value. So made significant progress over the last 3 to 4 years, and we think that will continue.
All right, good to hear. So how is CMS working to reduce the social determinants of health, Dr. Conway, and increase health equity across the United States? Especially, how can payers build on that progress?
So a number of different ways. In Medicare, through the Innovation Center, we have a model called Accountable Health Communities. We're partnering with communities to address the social determinants of health. And our Medicaid program, through waivers and other mechanisms, we address things like housing supports, food insecurity, transportation. So we're really working with beneficiaries and their families to address the social determinants of health across the board.
Very good, which of course would then build health equity so that more of the underserved feel part of the health system.
Exactly.
Terrific, terrific. All right, so in your opinion, Dr. Conway, where should payers be focused most as we prepare for the aging of America?
Yes, I'd say a couple things. I now have been in government a few times, so I've worked with 4 secretaries of health, 3 presidents. I just saw one of my former bosses, Secretary Leavitt, talking.
Very good.
He said any organization that delivers better health outcomes at a lower cost will be successful in the healthcare space. I think that's true. I think it's an economic imperative across bipartisan support on the Hill, but even more importantly, across the public and private sector. People understand we have to get more positive health outcomes for our healthcare dollar.
And are you seeing that happening more through collaboration? A payer maybe working with community resources? What's the right way?
We definitely are seeing a lot of collaboration. So I've been at CMS for over 6 years now. We work with all the private payers closely. My next meeting is actually with all the chief medical officers of private health plans. So we work together in new payment models in states and communities across the country. I think that public-private collaboration over the last several years has become very strong, and I think will be even more important in the future.
Very effective too. That's great. Okay. Next question for you then are what are the care delivery trends that you're tracking that will benefit those with chronic conditions, and how can we do better for this population?
Yeah, so the biggest thing I'd call out is our use of telehealth and remote monitoring and other technologies. So we're seeing, for example, in our comprehensive primary care model, which is a big primary care medical home model, heading towards 18 states now. Primary care practice using telehealth to manage chronic disease, using remote monitoring technology, really engaging with patients outside of the office visit. So they're really caring for patients where they work, live, and play.
Okay, outstanding. Good to see. So finally, as Deputy Administrator for Innovation and Quality at CMS, how might you use your role to advance the adoption of digital health technologies, AI, VR, even blockchain that could improve patient outcomes?
Yeah, so I think we're trying to do that in a number of ways. One, and we have payment models now where we pay providers similar to how we pay health plans. So we pay them, population-based capitated rates, and then we see them innovate with new technologies to deliver better care for patients. I also think we're using what we call our waiver authority, but it basically allows, for example, telehealth waivers, where providers then can use telehealth, store and forward, other technologies to really deliver better care for patients.
Very good. And I can't help but give a shout out to the Office of the ONC. I know that they issue all these challenges, and I think that that's a really innovative, very entrepreneurial approach to taking on some of the bigger innovative opportunities in the healthcare space. So yeah, it's always fun to watch those. All right, so Dr. Patrick Conway, thank you so much for joining us here in the GuideWell Insights Lounge. I know that you have a busy day, so please, you're going to be talking tomorrow, I believe?
Later today.
Later today. All right. Well, great to have you here first. All right. My name is Kate Warnock. Thanks so much for watching. we'll open with your
And you look at the camera, look at you.
look at camera. Yeah. Hi everyone, we're back live here in the GuideWell Insights Lounge. This is Kate Warnock coming to you from on location at the AHIP Institute and Expo. Delighted to have our last guest of the day, Mr. Ferris Taylor. Ferris, welcome.
Thank you. It's great to be here. It's great to be at AHIP.
We're happy to have you. So Ferris, you have two titles. You're both the chairman of the board of the Healthcare Executive Group, and you're also the CEO of Arches Health Plan. So you were just telling me before we went on camera that you just sat in and heard Dr. Eric Topol speaking. Tell me, give me, if you can, recap some of your top points.
I'd be glad to, and I'm a technology and data geek.
Yeah.
My
So you
undergraduate,
geeked out. Yeah.
And Eric is just phenomenal, and it's been a couple of years since I've heard him speak.
Yeah.
A couple of things that just really struck me is how accessible technology is becoming. Years ago, I saw him do an ultrasound with his smartphone, but now he did his full body ultrasound, and then he compared it to his MRI. And the power of technology plus the innovation that comes from the marketplace opens up a whole realm of opportunities.
Yeah.
What struck me the most in what he said, and it's something that's bothered me for years, is why is healthcare so slow in adopting technology? And we've all seen it. When I went into business school, it was the first time that a hand calculator was required. So I date myself, and this was long before Hewlett-Packard. But it was $400. And today here at the exhibit hall, they're giving them away.
Right.
At the same time, there was a pacemaker in 1973, and it was a few $1,000s. Today it's 20 some odd $1,000. And it seems like in most industries, over time, due to the technology, the quality goes up and the cost goes down.
Right.
And in healthcare, it seems the quality may go up some, but the cost definitely goes up. So we had a lot of comments about how the technology now that is available, a smartphone, everybody's got a smartphone. If that can be used, then that dramatically changes the cost curve. Another comment, go ahead.
Yeah, I was going to say, and it democratizes health too. I mean,
it does.
It really puts you kind of in control of your own health. I mean, I have to admit, I followed Dr. Topol on Twitter, and I don't know if anyone got to see. He actually tweeted his own kidney stone.
Yeah, he showed that.
He showed
today.
that, and
it was
tweeted
phenomenal.
it, and then he tweeted the after effects, and God love him, he had 3, but all right there with the technology in his pocket.
Just
right.
in his pocket. So the technology part is so accessible. Now we need the innovation and the quality to come along. Naturally, the smartphone ultrasound of his kidney stone could identify the kidney stone. It's not everything that an MRI might be,
right?
But it's very, very doable.
Right.
The 2 points that he made on adoption that struck me is, first of all, our industry has been very slow, very cautious. Back to my example of the hand calculator.
Yeah.
In comparison to what's happened with a pacemaker, now I understand a hand calculator won't kill you. That's not what hand calculators will do. And a pacemaker has a different standard. But where the hand calculator has gone from $400 to 13 cents, and it's the size of a business card with a solar panel on it.
Right.
The pacemaker has gone to tens of thousands of dollars. And why is it that we are ultra cautious with the technology and we leave the consumer out of the picture? So how do we as a society, Governor Levitt spoke right after Eric Topol and talked about the clash between the economics and our social and moral obligation to the citizens of the world, actually. And we have to be able to afford it. So are those incremental improvements in quality worth that expense? Part of it is just the medical society. We've got to have double-blind tests and all of the regulations that come into that. And at some point, we're going to have to break through that. The third point that I thought was just very revealing is we do not calculate in this high cost of healthcare, $3.4 trillion industry that we're involved with. We don't calculate the cost of the consumer, the cost to the consumer. Telemedicine is a good example where, and Dr. Topol and I both agree that the RAND study was in terms of research that said, well, telemedicine really increases the cost. It was poor research, there were some flaws in the research, but what wasn't in that cost was a mother with 3 children that has one that gets sick and has to get Susie to the piano lessons and Johnny to the baseball game, and life comes to an end to get to the doctor's office versus a phone call.
Right.
What's the cost to the patient, to the member of healthcare? So those were my quick takeaways, but I love Eric Topol. I love technology. And I do think that we're on the cusp of having the technology that it takes to really change this complicated industry that we're involved in.
Outstanding. Well, I'm going to jump to another topic that's related. Maybe just give me your quick sense, Ferris, around cybersecurity. We talk about cybersecurity, the protection of patient data, how critical that is. Tell us, what do you see in the future?
Again, the innovation is going to come from the flow of data, and we really want to emphasize the big data, and as was said in the opening session, the big analytics that have to go with that data. But as you move healthcare data around, it's a little bit different than other industries. And I've made the comment many times that in terms of cybersecurity, so many of us in healthcare have said we have the same security standards as the banking industry. And I challenge that in the sense that the banking industry doesn't really have a security policy. They have a remuneration policy. If money goes missing from your account, they put it back into your account, no harm, no foul, nothing's been lost. In healthcare, lots can be lost if our medical information gets lost. And I think the future there is again in technology. The internet wasn't created for us to be able to have secure conversations. It's an open system. But the technology is there that we can now have point-to-point communication systems. So if I want to invite my neighbors to a barbecue, I send an email out. But if I want to transact something with Kate, financially or medically, I send your medical information. I want that to be just you and me, secure from both ends of the system. So to be able to do, the technology is there now to be able to have a private internet. And private email tries to do that, but it doesn't really work because the endpoints are not secure. First time you get a message from a secure email system, you go on, you register, put in your user code and password, and you've got a secure message. The next time you get a message and it says click here and put in your password, and you click there and put in your password, and somebody sitting in Romania now has your password. And it must have been important because you sent it in secure email. We've got to move beyond that to secure communications in healthcare.
Yeah, well, Ferris, I mean, I think the themes that you touched on, technology, the fact that it's becoming, practically frictionless, but still too expensive, and the fact that our data, to be meaningful, has to be both secure yet still shareable. Big themes that are here at AHIP, and I think there's going to be a lot more conversation over the next couple days. So I'm so glad that you teed that up for us today and joined us here.
And thanks to GuideWell for doing this.
Oh, our pleasure.
We love what you're doing to perpetuate the thought leadership in the industry.
We're so grateful that you joined us as one of those thought leaders, and look forward to streaming more interviews live for our audience over the next couple days with more people like Ferris Taylor. Thank you so much for watching. My name is Kate Warnock. We're going to be up with more interviews tomorrow. Please tune in.